going to run posterior to the bladder, and then the cervix would be the lower portion. It's hard from our standpoint on CT, ultrasound a lot easier to distinguish between the body and the cervix. In terms of what we used to call fallopian tubes, now in Gray's Anatomy, they call it the uterine tubes. So that's the new term for it. The uterine tubes are going to extend from the area of the fundus. It's going to continue over here and reach around. Here's your ovaries. It'll be bilateral, at least in most patients. And basically what happens during ovulation, I won't get into the cycle, but eggs will be released by the ovary. And these little fimbriae out here are little fingers, and they're activated or stimulated. Little hairs on them called cilia. And what happens, the egg's going to migrate up here, typically to the mid portion of the uterine tube. Sperm will come up, fertilize it, and then eventually the fertilized egg is then going to drop into the uterus, and then through implantation, it will connect through a placenta and develop and things like that. In some cases, what happens is you have fertilization of that egg, and then it doesn't migrate, and that's what we end up with, a tubal pregnancy. And that usually means the demise of the uterine tube. Other cases, which is really unusual, you'll have the egg actually move, after it's been fertilized, move retrograde, because there's no direct connection between the fimbriae, and the ovary will drop right out and go into the peritoneum, and you have like a dermoid cyst that will develop from that standpoint. Over here, we're going to talk about ligaments. The main one's going to be called the broad ligament. We'll talk about those here in a second. There are certain connective tissues that anchor down both the uterus and the ovary. Here's an important point I want to make. Again, we have the three divisions over here. And this is a typical uterus. Not that they're all this way. But what you're going to have is you're going to have the fundus as we cut from top to bottom. The fundus is going to be what we call anti-flexed over the top of the urinary bladder. So it's going to be kind of angled in this direction like this. And then as it goes down, it's going to run posterior to the bladder. So you start off by cutting, you'll see uterus, which is a homogeneous density. Then you'll get into the bladder area, which may or may not have contrast media. And then it cuts down into the body of it from that standpoint. We'll talk about certain pouches or cul-de-sacs that occur in and between these different structures. So again, as you work your way down, you'll see that uterus move posterior to the bladder. It's one of the reasons why for women who've had children, as the baby gets larger, you put more and more pressure on the uterus, and of course it drives you to have more frequent visits from that standpoint. All right, so we have three layers that make up the uterus. We have the outer one called perimetrium, which is a very fine layer, outer serous tissue of the peritoneum. You have the muscular part called the myometrium, which is the densest part through here. And then you have the endometrium, which is the inner lining. And sometimes you'll get reactions to that endometrium. You end up with things like endometriosis, which basically is an inflammatory process of this area, and it can be a problem from that standpoint. The center would be the uterine cavity itself. And again, look at the proximity on a coronal. You'll have the bladder up here. You'll have the uterus, in this case, probably the body of it, running posterior to the urinary bladder. That bladder, when it's filled with contrast or fluid, again, we always kind of think of it as being round. In reality, it's more block-like than we might imagine. The ureters oftentimes will come in from the posterior lateral side, and we'll show you those as we progress through our overview. Okay, for imaging professionals such as yourself, it's one thing to know the anatomy, and again, we have the bladder over here, symphysis pubis. We have the rectum that's going to be coming in and down. So part of the rectum is going to be within the retroperitoneum. The other part's going to be infraperitoneal. In fact, this little green line over here is, in essence, the boundary of the peritoneum. So you can see that based on its position and location, it meanders through. It will create both pouches and what we call here a reflection. We could also call it a pouch. Here you have a large one that was referred to in old terms as the pouch of Douglas. Now we call it the recto-uterine pouch. That's a new term in Gray's Anatomy. And what this implies is sometimes you'll have tumors, sometimes you'll have diverticulosis or ticks that will actually breach through the wall, and you can have infections in this area. So advanced imaging, in the case of all of your modalities, you look for any abscess, any fluid areas in this area, which may indicate an artificial opening or a fistula. More significant, you have a tighter breach, or tighter connection rather, between the uterus and the bladder. We call that the uterovesical pouch, sometimes called reflection. In this case, when you have breaches because of tumor or trauma, again, there's almost a direct connection between the two, and this would be an opportunity for a fistula to develop from that standpoint. So there's imaging significance on these pouches. They are indicators of abscess, ascites, infection, fistulas, things like that. So you need to be mindful of those. Over here on this perspective over here, you're looking at a sagittal. Again, you're going to have the uterus antiflexed over the urinary bladder, which is down here. And you got the rectum coming back here and down. Here would be the area of the rectouterine pouch, again, formerly known as the pouch of Douglas. And then you have that one right between here, which is quite small, called the vesicouterine pouch. It's just nothing more than a small space. But again, you have the opportunity for breaches between the rectum, the bladder, and rectum and the uterus on the female, and the uterus and the bladder as areas of concern in terms of tumors. So again, you want to be aware of those. All right. Again. All right, from a coronal perspective, again, we're kind of being redundant. Bladder over here, uterus right over here with the uterine cavity, which will vary in terms of its dimensions or size, and that small vesicouterine pouch right through here from this perspective right here. I'm going to make reference to ligaments and muscles later on, a lot of those, unfortunately or fortunately, in the pelvis. But you have on this coronal over here a V-shaped muscle over here called the levator ani. We'll talk about it here in a moment. But why this is really important, that individuals as they get older oftentimes will have prolapse of different structures, whether it's uterus or it's going to be bladder, even rectum. What holds things in check is this little V-shaped muscle right through here called the levator ani. And basically it holds everything up in terms of its position, normal position in the pelvis. So oftentimes when we're doing imaging, especially as a person gets older, we get worried about prolapse. And that will be an important structure to evaluate to see if there's any signs of weakening of it from that standpoint. Ligaments. We're going to primarily focus on one referred to as the broad ligament. It's the largest of the group. But there basically are a series of 3 ligaments that are going to anchor, first of all, the uterus in a posterior sense, but also from a lateral sense. And that's kind of the function of this first one, the broad ligament. The round ligament is going to support the uterus on a side perspective, which oftentimes will be found, we'll show you a better image here in a moment, on the upper margin of that broad ligament. And then you have an ovarian suspensory ligament that's going to somewhat fix the ovary, all of which become significant from the standpoint of any prolapse or movement of the uterus. Over here, better sense, what you have is this fan-shaped structure is a broad ligament, quite dense. Here's the uterus. Again, it's going to provide support laterally for the uterus. You have your round ligament, which doesn't really show its design. It's going to actually be embedded in the upper portion of the broad ligament. And then down here, you're going to have some other ligaments. Here, you're going to have the uterine tube back over here. And I don't think over here would be the ovarian artery and nerve. I don't see the ovarian ligament in this case, but basically it's going to support it from the standpoint of its movement as well. The broad ligament is the one that's going to stand out from the standpoint of being, oh, here's ovarian ligament right over here. I stand corrected, right over there. We'll look at imaging and see how that appears. From a coronal perspective, MR, what you have is uterus here, they're going to vary in size. Here's that broad ligament laterally, which is going to anchor it down. Up here, a little bit partially seen, is going to be the ovary. Back over here is that levator ani. You get that little wishbone-shaped structure like this. That's going to support the pelvic floor, keep things from prolapsing from that perspective. Again, what you see here, perhaps the most important landmark, is going to be the broad ligament of the uterus. We'll get into muscles later on, and we're going to find out there's certain muscles that will extend from the ischial tuberosity up to the symphysis pubis, and there's some that are found outside of it, in a general sense. This first one over here is going to be called the obturator internus. We'll look at a better image of it here in a moment, but again, there is a lot of muscles. We're only going to touch upon a few of these, and you'll hear terms like obturator externus and obturator internus in terms of what these structures look like. Questions on that? Some of this familiar? No. Okay. I'm glad to first bring it to you. All right, round ligament. I'm not going to spend a lot of time on that. Basically, it's going to be found in the upper portion of the broad ligament right over here, and it's going to help secure the lateral aspect of the uterus, kind of hold it in check. You're going to have the ovarian ligament back over here that's going to help secure the ovary. And you have a lot of tissue in here that's going to be supportive connective tissue. From a CT perspective, here we're looking at an axial perspective. So it's kind of sometimes based on what you're looking at. Here we have the fundus, and then you're going to have the body. What's missing here on this early shot is going to be the urinary bladder. The urinary bladder will be an important landmark because the fundus oftentimes will be antiflexed over it, and if we've introduced IV contrast, you'll see the bladder filled with contrast, and then the body's going to run posterior to it. The rectum would be the most posterior portion over here. Here you have a little ovary, kind of hard to pick up, and then you have the anchoring of the round ligament. We're going to talk about these muscles again, but over here is going to be one of the gluteus muscles over here. We'll get into these guys here in a moment, along with the obturator internus and others to follow. So there's a lot of muscles in the pelvis that we're going to discuss. We'll kind of break them down for you as we go through. The ovaries, again, are paired. They're not directly connected to the uterine tube. There is a division between them and the uterine tubes. They will sometimes be very easy to pick up, other times they're not. In this one example, you're able to see them labeled for you. You have the ovary over here. In essence, the broad ligament's going to be fanning out like right over here. Ovary, round ligament. I would not expect for you to be able to pick that up, but in certain cases, you'll be able to see it on an oblique version of it. The uterus, again, is going to have a very thick myometrium, the muscle itself, and then you have the smaller, in this one instance, of the uterine cavity. The bladder is semi-empty, so that's what you're seeing over here, and the urethra would be below it. So broad ligament, round, I'm not too worried, it's running linear like this. Here's ovarian ligament, hard to pick up. Here's your ovaries on both sides. Back over here is your bladder. Down here would be the vesicouterine pouch, which doesn't really stand out, but we simply know about its location. Once again, on this MR, from a landmark perspective, urinary bladder, uterus down through here, ovary in this area, not so much seen on the patient's opposite side. This little triangle-shaped structure is the uterine cavity over here. Here on CT, especially the examples I'm sharing with you, not very evident where the ovaries are. Again, will help you better distinguish fundus from body once we see the bladder, because the upper portion would be the fundus as we cut our way down, superior from inferior, and you'll see that transition of the fundus moving into body and cervix. Probably a little ureter right over here. We'll look at that better along with the round ligament. So we'll take you through these systematically, certainly on Thursday. It's kind of just an overview at that standpoint. Male, in terms of key landmarks, you have prostate. We'll get into small glandular structures that help provide somewhat of an energy source for sperm, called the seminal vesicles. You have the spermatocords, which are going to be found very anterior, also referred to in part as the vas deferens. And then you have the prostatic urethra. We'll talk about that part. It's the portion of the male urethra that goes through the prostate that can be compromised as you develop BPH, or benign prostatic hyperplasia. So that's something that we image from that standpoint. Here we have an image of that area. We have the urinary bladder up here. And we'll talk about these better here in a moment. Here's your seminal vesicles. We'll see them better on a transverse slice here in a moment. You have the prostate, which is shaped of an almond. At least in the healthy person, it's quite large. And you can see its proximity to the floor of the bladder. So as you develop hypertrophy of the prostate, it begins to put more and more pressure on the bladder, and males begin to have frequent urination. They're unable to pass urine, things like that. The prostatic urethra is running right through the center of it. So again, as you get older, what happens is the prostate will become more fibrous, it becomes enlarged. Not only will it put pressure on the bladder, it also restricts flow through the prostatic urethra, and that's when they do things like TRUPs or TURPs, go through and open up that urethra. So something that we all have to look forward to, I guess, as males. It's only fair, right? Females go through so much, it's fine that now males. You know, there's something said about the fact that if you live long enough as a male, the males get prostate cancer. So there's a lot of interesting information on that right now. At a certain age, they stop doing PSAs, I don't know if you knew that. And then after that, if you develop a prostate cancer, the conventional thinking right now is you don't treat it. So it's kind of, because basically it's a slow growing tumor. You get prostate cancer in the 30s and 40s, it's a different issue altogether. There's a great tendency to have it metastasize the bone and other tissue. But for the most part, the prostate is going to go through fibrous changes, and the risk of cancer is quite tremendous. Again, basically it's going to help in terms of producing fluid for the propagation of sperm. What you see over here are the seminal vesicles. Here you have this little area right through here and right through here. This basically is the seminal vesicles. Over here, not the greatest image of it, but oftentimes radiologists will call it the bow tie sign. It has a concentric area, which actually right over here is where the vas deferens are located at. So this is where you would, at least in part, snip for a vasectomy. And here you have that more divergent lateral portion of it. So you'll find it between the bladder and the rectum, given the fact they use IV contrast or an MR. So here, over here, would be seminal vesicles, back over here as well. Directly posterior to the urinary bladder and anterior to the rectum. Okay. More of a consistent landmark over here. Once again, urinary bladder, seen in a partial sense. Contrast-filled rectum over here. And at least on one side over here, you get that consistent, somewhat of a, again, we use the term bow tie sign of the seminal vesicles right over here. And they're an important image in terms of possible spread of cancer, primarily from the prostate itself. So again, going from anterior to posterior, you're going to have the bladder, you'll have seminal vesicles, and then the rectum, whether it's enhanced or not. And we'll cover the muscles here in a little bit. Questions on that? All right, ultrasound people, along with others, certainly ultrasound. When you have a patient who has an elevated PSA, oftentimes you have to scan, and I'm not sure if this is under your, do you guys do prostates right now? In your, are you other techs doing them or not? They're not probably physicians? The physicians might be doing them. They use a transducer, they insert it rectally so they can isolate the prostate. And the prostate itself is going to have a couple areas. One is going to be the central zone right up here, and then you have another area called the peripheral zone. Basically, each of these areas, at least in a healthy prostate, has different degrees or percentages of glandular tissue. What they find is that prostate cancer oftentimes will emanate from these areas based on the percentage of glandular tissue. So when they do these biopsies, something for all the guys to look forward to, I guess, is they will place both a transducer transrectal, and then they'll place a device in there that will then actually do biopsies. And what they try to do is sample all of these zones. So when you're doing these, you're going to find they'll be looking at the central zone, they'll be looking at the peripheral zone to see if there's any signs of changes or possible cancers. They have to do, my buddy just had one of these, and I think they did, I don't know, a dozen biopsies, because they have to sample both sides, and they have to look, again, at the central and the peripheral zone from that perspective. Here are the seminal vesicles right over here. And again, they're not really too involved unless there's metastases of it. And then right down the pipe, right down the middle, is going to be your prosthetic urethra. And again, based on hypertrophy of the prostate, you can cut down flow, and once again, that could be an issue. That could be normal BPH, or it could be due to cancer from that perspective. Another shot of the prostate, and again, those two areas that you have to be aware of called the central and the peripheral zone, and along with the rectovesical pouch. All right, structure on anatomy. I'm going to turn the lights on for a moment, and you're going to have to endure my artwork, so I apologize for that right off the bat. If I put this on mute, it's a dangerous thing to be doing, but I'm going to do it anyway. All right, so where we left off in the abdomen, we had the bifurcation of the aorta, for example, right around L4 to L5 begin. And what happens basically is you're going to have your aorta coming down, and then it's going to go through a bifurcation. Again, early apologies for the poor artwork. So you have your AA over here, abdominal aorta, and then over here at this level, you have common iliac arteries. We'll see that right around the area of L4 to L5. Right around the area of the sacrum, then there's a second bifurcation that occurs. There's one branch that's going to come off this way, and another branch is going to come off this way in this direction. What you have is bifurcation into the internal iliac artery, and the one that's going to run, of course, lateral is going to be the external iliac, here I'm not doing the right, external iliac artery right over here. This will happen right around the true pelvis. These guys here are going to quickly go into small collateral arteries that are going to feed the urinary bladder, the rectum, prostate, connecting tissues, so they don't stand out that much in terms of a landmark. These guys here are going to begin to move from the midline back up this way, and they're going to follow the contour of the anterior portion of the ilium. It's still going to continue to be external iliac arteries. Then what's going to happen, they're going to come up near the area of the femoral head right over here. Again, my artwork is at its very worst. And there's going to be a very dense ligament that they pass beneath them called the inguinal ligament. And at that point in time, you have a transition right around the femoral head into femoral arteries. So typically we can't see the inguinal ligament, but when we see the femoral head, the general understanding that transition has occurred from external iliac arteries into femoral arteries. So that's the landmark or benchmark we're going to use, and from that point down we'll get into extremities later on. So again, abdominal aorta right around L4, area of the sacrum right over here, is going to then have bifurcation into the external and internal iliac arteries. These guys are going to move up this way and then eventually come over in that direction. Here's the point about these guys right over here. There's going to be a point when they're running, at least on an axial perspective, perpendicular to the fan beam, so we get a nice round appearance. When they begin running parallel, rather than round, you're going to get somewhat of an elongated artifact, because they're not going to have that nice distinctive 90-degree perspective. So you lose them as they're moving up the sacrum. The IVC will do the same thing, except it's going to be posterior. What's going to happen is that as we go through the IVC over here, the same kind of bifurcations will occur. You'll go into external iliac vein, internal iliac vein, and then it comes up this way. You're going to have two structures that will start off before they make that turn parallel, one larger than the other, and one more posterior. So you're going to have the external iliac vein, posterior and larger in diameter, compared to the external iliac artery. When they make that cross beneath the inguinal ligament, now what you'll have, larger posterior, is going to be femoral vein. So a couple benchmarks we need to be aware of. One, bifurcation of aorta, an IVC into common iliac artery and vein. The external iliac artery, the internal iliac artery and internal iliac vein quickly get lost in terms of other structures within the area of the true pelvis. And then as they move their way laterally, you're going to have a larger, more posterior external iliac vein and a smaller, more anterior external iliac artery. What do you think? That makes sense? Let's look at it from a sectional perspective, see if I can get this baby back on. Wonderful. First time in history that's happened. Okay. So over here, we talked about it before, the IVC is going to be the patient right over here. The aorta is going to come down right around the area of the iliac crest. You have the first bifurcation. If we look at the artery alone, then it's going to start down here, get near the area of the true pelvis. You have another bifurcation into the internal iliac artery, and then it's going to continue down into the external iliac artery, and eventually, it doesn't show you the transition, it goes beneath that inguinal ligament, and at that point in time, it becomes femoral artery. Vein, same thing, bifurcation, usually right around L5 or a level below it. It goes into common iliac vein, external, internal iliac vein, and eventually when it goes beneath the inguinal ligament, now it transitions into femoral vein. Again, a little bit different perspective what we're seeing over here. That bifurcation, these guys are simply not going to stand out as landmarks in terms of the arteries from that end, or veins for that matter. Let me jump ahead. Over here is a recon, so what you have over here is, in this case, the aorta coming down, producing the bifurcation into common iliac arteries, right around the area of the true pelvis, which we can't see. It goes into internal iliac artery, coming out laterally, external iliac artery. Over here on a axial perspective, over here, the IVC is going through transition, and already we saw this early in the abdomen unit. We're just barely getting into iliac crest over here. It goes into common iliac arteries. They're going to be anterior to what we see eventually in regard to common iliac veins. Let me get that right if I can. IVC, we talked about it. It'll be a level below it. Here you have the vein basically coming down on a modified sagittal. It will go into common iliac artery over here. What's the artery inside the vein? Let me jump ahead on that one. So there's going to be some confusion as we look at these as we begin to go down there. So what happens is you're going to have external iliac vein back over here, and because they're beginning to run transverse or run parallel to the fan beam, you'll get external iliac vein posterior here. Here's our psoas major muscle, and then the external iliac artery is going to be anterior and smaller to it. Here we don't see the external iliac artery, but we do get into an internal over here. We're going to somewhat ignore these guys. These are very hard to pick up because they're small and they quickly break down once they get below the sacrum. So we're going to be focusing primarily on common iliac artery, common iliac vein, until we follow them both through the transition into femoral artery and femoral vein. We'll talk about the muscles as we work our way down that area. Once again, a different perspective over here. You have two large densities right over here. We'll focus on these guys over here. External iliac vein, and what's anterior to it, smaller diameter, external iliac artery. Ditto over here. These guys down here are hard to pick up, but you would have internal iliac artery, and then vein would be posterior to it. We're going to focus on these structures going up the anterior portion of the pelvis, the iliac crest, until they meet the femoral head area. External iliac vein, larger in diameter over here, and more anterior, external iliac artery. External iliac vein here, smaller, external iliac artery. These aren't the best images, but you see that transition of the external iliac artery and vein right near the area of the true pelvis. Once again, another example. We can't see the inguinal ligament, so that transition, from our standpoint, is once we see femoral heads, we're going to assume the transition is complete. We've already passed beneath the inguinal ligament, the larger of the two and more posterior femoral veins. What's anterior to them would be femoral arteries, and again, they're going to continue to move out toward the periphery of the structures. Again, arteries over here, femoral heads over here, and that's where that transition is beginning to occur. Questions on that? We'll look at better examples here in terms of contiguous slices. Hopefully it'll make more sense as we look at it from that perspective. All right, if you like the arteries and veins, you're going to love the muscles, okay? And over the years, what I've found is that we have to kind of break it down into 4 different areas. We're going to talk about the anterior and posterior iliac fossa. So what's behind the iliac crest is defined as the posterior iliac fossa. What's found anterior is, of course, going to be the anterior iliac fossa. In the anterior iliac fossa, the major muscles we're going to catch would be the psoas major and minor. We'll combine these into simply psoas muscles. There's one that's going to be lining the inner layer of the anterior fossa of the iliac crest called the iliacus. What you'll find is through a transition, this guy here will make them combine, will eventually join up with iliacus, and the product will be iliopsoas. So here, these two come together, they join up, and these always are kind of together. They'll join up with iliacus, which is lining the anterior portion of the fossa, and the form iliopsoas. On the outside or posterior portion of the iliac fossa, you're going to have the 3 gluteus muscles. You're going to have the smaller of the set, which is the most intimate against the bone, call it gluteus medius. Medial is called gluteus medius. And then the outer layer, larger of course, would be gluteus maximus. Of the 3, in terms of cutting from top to bottom, the first one that will show its insertion point first would be gluteus medius. So as you cut your way down, you'll see this guy first. And then later on, you see all 3 of them based on this fascia that separates the 3 muscles, helps us distinguish what they look like. In the pelvis itself, the true pelvis, we talked about these guys. They're going to provide stability to the pelvis that gives us the ability to flex and abduct the legs. There's going to be one that's going to run internal to both the iliac tuberosities and the symphysis pubis, and they run somewhat vertical. There's one on the inner layer called the obturator internus. There's another one that will be found lateral, somewhat running oblique to the symphysis pubis called the obturator externus. And then one we talked about before that provides support for the pelvis is called the levator ani. These guys out here are going to be found in the pelvis, and we have to pretty much identify these as we go through learning about them. This is going to be the product of the psoas muscle and the iliacus, and you'll be able to pick that up from where it first joins all the way down to the head, or region of the head of the femur. The sartorius has the unique quality of being the longest muscle in the body, and we'll show you where that occurs. The rectus formaris is one of the quadriceps. We'll talk about it. The tensor fasciae lata helps us with abduction, or TFL. And the pectinus basically is going to help us with abduction, found anterior to symphysis pubis. So the only way to really learn all these muscles is to break them up into 4 quadrants. What's found within the anterior fossa, what's found posterior, what's found within the true pelvis or inlet, and then finally, what's found in the greater or false pelvis. The quadriceps basically are 4 muscles, and we'll get into more of this as we work our way down into the extremities. These are the 4 muscles that make up the quads. Eventually what's going to happen, will come together, they'll form the quadricep ligament and tendon, and eventually they insert at the tibial tuberosity. So your quads are right over here. The hamstrings, again, we'll look at later on in extremities as the muscles found in what we call the posterior compartment. So basically, what you're going to have is a mechanism for flexion, which is the hamstrings, and extension, that's going to be a function of the quadriceps. The piriformis and IT band, we'll talk about those as being independent. This one will be found within the lower portion of the pelvis. And this one is your IT band that some patients, runners, and others will complain about in terms of pressure to it. When you look at the IT band on a cadaver, it is paper thin, and you're kind of surprised in terms of the problems that can occur with the IT band. All right, so here's what we have. I'll kind of walk you through these in terms of, here's our pelvis, of course, here's my sacrum. Here's the psoas, and we're not going to worry about minor versus major. We'll simply refer to it as the psoas muscle right over here. And what you're going to find, it's going to stand out independent, but as we work our way down the pelvis, these two muscles will combine, and the product is going to be psoas muscle. So they're going to basically come together and form a new muscle group. Here is a posterior fossa of the pelvis, and based on fascia, the smaller of them is going to be gluteus minimus. Right over here is medius, which inserts the most superior, so we'll see it first, and the maximus will be down here. So you have posterior compartment, anterior compartment right over here, and you have psoas eventually will show up along with the gluteus muscles posterior. Here again, labeled for you, minimus, medius, and early on, maximus. Once again, psoas muscle over here, minor and major, and then the iliacus is right over here. As we work our way down, they begin to combine. So when we get into the true pelvis or near the ilium portion of it, they'll come together, and what you have again is a product of psoas muscles forming. Here is that same process occurring along the posterior fossa. Once again, gluteus minimus, medius, and maximus along that posterior portion right through here. Once again, now you have that transition, so you get somewhat of a unification of the muscles. From this point down to the area of the greater trochanter, now you're going to have the iliopsoas up here. These muscles will continue until they transition out. So you have over here iliopsoas, both sides. You have the gluteus muscles on the posterior side. Although they're hard to pick up, here's that artifact we talked about. We're in the area below the pelvis, or the sacrum rather, before we hit the femoral head. Although it's artifact, you're going to have external iliac vein here, external iliac artery, and ureters are coming in right about there, given the fact that we have IV contrast. And we'll get into the GI tract later on. Here, I'm not going to worry about the rectal ligament, although it does show up. Here we're getting down to a point where you're starting to transition near the area of the acetabulum and the femoral heads. What we have over here is iliopsoas right through here. Gluteus maximus is all we're going to see on the posterior fossa side of it. The rectum is down here, and in partial sense, you have the urinary bladder. You have a muscle that makes up that lateral compartment that has somewhat of a unique shape to it. It starts up over here, and then it kind of tapers in, almost like a hook. We'll see it more distinctive here in a moment. That's going to be what we call the tensor fascia lata. It's going to be over here that comes down and around. And then this little thin layer right over here, and somewhat over, I don't quite see it on this side over here, but this little thin line over here is going to be your IT band. So as we work our way down the pelvis, and we'll break this down for you in contiguous slices, we have this. We have the urinary bladder. I got the rectum, IV contrast. We're not to the heads yet, so we can't quite pick up over here is the area of the artifact, external iliac vein and artery. We have gluteus maximus down here, posterior, and then we have that hook-like projection, which is tensor fascia lata. We simply abbreviate it TFL. Going down, here's what we're dealing with. We have ilium psoas right here. We have this muscle over here, seen on both sides, called the rectus femoris, one of the four quadriceps. The most anterior on both sides is the sartorius, which is the longest muscle in the body. Basically, it's going to extend from the area of the pelvis down toward the femur and eventually insert along the anterior portion of the tibia. So you have the sartorius over here. You have tensor fascia lata over here. That thin band over here, both sides, doesn't quite show up on this side very well, because it does over here, is your IT band. What's left of gluteus maximus down over here. This guy here, here's your ischial tuberosities. What's running medial to them and vertical is going to be obturator internus. Here's our symphysis pubis. And we'll look at this guy here in a moment in terms of external obturator externus out here. We'll break that down better for you. And then finally, there's one that runs anterior that you need to be aware of called the pectinus, which helps with both flexion of the lower leg and abduction. So around the horn, what you're going to have, and I know it's throwing a lot at you, is the following: iliopsoas, sartorius, most anterior, one of the quads, which is rectus femoris, TFL, IT band, vastus lateral. We'll get into more detail on that one here in a second. Gluteus maximus, obturator internus, in part obturator externus, and the pectinus is going to be found anterior to the symphysis pubis. So you have a lot of muscles, I realize. It's kind of the nature of what we're dealing with. Here's another labeled example for you. You have TFL up here. You have rectus femoris. You have iliopsoas over here. Sartorius up here. Once again, a little bit easier to pick up on this male. You have obturator internus, wishbone-shaped structure that goes like this, called the levator ani. Prostate gland, probably because of a catheter, we have, with contrast introduced, prostatic urethra, rectum, with some kind of enema tip in place. So, and of course, gluteus maximus back over here. A lot of anatomy, I realize, but these structures are kind of important. And the only way to really break them down is anterior, posterior, what you find medial in terms of the true pelvis. Because that really adds to a lot of your knowledge from that standpoint. Here is a different coronal perspective. Once again, obturator externus is coming off from that direction. Internus like this. We won't worry about this image, but you have the gluteus medius. Maximus is going to be out here, and your TFL will be what? We won't worry about that one. There's a lot to throw at you. Sagittal, same thing. You're going to have obturator internus. You're going to have the sartorius. You're going to have the rectus femoris. And then directly over here is going to be iliopsoas. We're going to primarily focus on the axial perspective. Questions on that? That's a lot, isn't it? I think we all agree. A couple things I want to cover right now, and then we'll begin. This will give me an opportunity on Thursday to go through contiguous slices. Just a couple more things I want to cover with you, if I may. Iliacus is right here. Psoas muscles is right here. Gluteus minimus, medius, maximus on the side over here. One of the things you're going to find, and we'll be showing you contiguous slices that will build better, is that when you have the sigmoid colon, as the term would indicate, it has an S turn like this as it makes its turn. So that's one of the characteristics, at least we see it more in the male pelvis. So this is part of the sigmoid colon as it begins its turn like this. On this side, once again, we have psoas. I have iliacus, minimus, medius, maximus. True sacrum over here. Going down, I have external iliac artery, external iliac vein. This little dot over here is contrast filled ureter. Sigmoid is going to make the S turn, beginning to transition to rectum over here. External iliac vein, artery can't quite see. Once again, ureter here, ureter here. Creation of iliopsoas, posterior fossa, minimus, medius, maximus down here. Same thing before it, with the exception of that transition going into, from sigmoid, going into rectum, which swings back midline. The ureters will be contrast filled, at least in this one example of the pelvis. Continuing down, we still don't pick up true femoral head. So the assumption would be this: we're beginning to turn parallel. So what we have over here, external iliac vein, external iliac artery, more anterior. Sartorius is just starting to transition over here. TFL will have that hook-like projection quality of build around it, right through here. And the one in the lower portion is going to be the gluteus maximus. Urinary bladder, rectum. On the male, you have the seminal vesicles, which we create what we refer to as the bow tie sign. Going down, once again, perhaps the best shot of it. Here we're picking up femoral heads. So we presume the external iliac artery and vein have gone beneath it. They have now transitioned, when we see the heads, into femoral vein, larger, more posterior than femoral artery anterior to it. Taking around the horn, we have sartorius, TFL, back to iliopsoas, IT band continuing down over here, gluteus maximus over here, band of tissue here and here, obturator should be internus right through here rather than femoris. Sorry about that, typo. Here's the pectineus over here. Once again, we see the transition femoral vein, femoral artery, sartorius. In this case, not quite, it's right over there. Rectus femoris, TFL. We'll get into the vastus lateralis later on, but here's the IT band emanating from it. Oh, let me go back. Prostate over here, homogeneous density on the male. Down here is going to be the rectum. The only difference over here, a little bit more detail, the muscles, once again, iliopsoas. Here, sartorius, rectus femoris, IT, or the TFLs over here. Gluteus maximus, obturator internus, both sides. Prostate, contrast fill, prostatic urethra. Pectinus is found anterior to the symphysis pubis. Female. The only difference you're going to get on the female, and these aren't the best images, but it's what I have, over here is going to be the uterus. We'll see it first show up in the upper portion, which we have to presume is the fundus. Because of the presence in this one example, rather than an S turn of the sigmoid like this, it's going to be deviated, so it's going to come off this way and eventually end up in the rectum. We'll worry about the muscles mostly on the male. Jump a little bit better. Here's the uterus over here. Sigmoid colon coming down, beginning to transition into the rectum. Here we have bladder starting to show up. What we have over here is ureter on both sides. Fundus over here, sigmoid coming down, transitioning into rectum. We'll worry about the piriformis later on. These two muscles over here. Continuing down, I have a little hint of fundus, contrast-filled bladder, body of the uterus running posterior, and down here, rectum. Obturator internus a little bit over here. We don't quite see the externus. We're not quite to the point over here of seeing the head, so we have external iliac vein and external iliac artery, and that's it. That's a lot, isn't it?